Thank you. Thank you.
Thank you so much, ma'am. Now I would like to invite Mansha Singh ma'am to the podium to chair the session. She is consulting dietitian and clinical nutritionalist and diabetes educator. She is pursuing a course in leadership program on nutrition security and sustainable diet. And she is also a fellow in applied nutrition. Ma'am, please join as a chairperson. I would also like to invite Manjari Bajpai ma'am to the podium as a chairperson. She is consultant dietitian at DS Research Center Varanasi and secretary at IAPEN Indian Varanasi chapter. And she has conducted several seminars and workshops on diet and nutrition. Thank you, ma'am. Thank you for coming.
Good morning, everyone. Our next speaker for today's session is Dr. Vinod Abhichandani. He is from Ahmedabad. And his topic for today is diabetes and thyroid disorders, a case-based presentation. We welcome you, sir.
Thank you very much, honorable chairpersons and all esteemed colleagues. Now I start sharing my slides. Over the next 15 minutes, I will relate to the two most common endocrinopathies we come across in our day-to-day practice, that is diabetes and thyroid disorder. Are my slides visible? Can somebody give me a feedback? Are my slides visible?
Okay. Yes, sir. Yes, sir.
So, thank you so much. So I'm going to take through all of us through a set of slides followed by 4 brief case presentations. So diabetes mellitus and thyroid dysfunction, that minimize this here, are common endocrinopathies that frequently coexist. In India, the prevalence of hypothyroidism in persons with diabetes is approximately 26.8%, and that of subclinical hypothyroidism is around 22.2%, with females being more prone to these disorders. Hyperthyroidism was observed in around 2.2% of persons with type 2 diabetes. All references are at the bottom. And in Indian patients with diabetic kidney disease, the prevalence of hypothyroidism was 34.1%, of which almost 85% were harboring subclinical hypothyroidism. Type 2 diabetes impairs the conversion of thyroxine, that is T4, to triiodothyronine, that is T3 in the peripheral tissues. Poorly managed type 2 diabetes accompanied by insulin resistance and hyperinsulinemia can induce thyroid tissue proliferation and increase nodule formation and goiter size. What about hyperthyroidism? So hyperthyroidism and thyrotoxicosis can worsen pre-diabetes and aggravate hyperglycemia in type 2 diabetes patients, increasing the chance of these patients developing diabetic complications. So how does this happen? Whenever there is excess of thyroid hormones in the body, they instigate increased hepatic glucose output, and this is mainly due to upregulation of GLUT2 receptors which are present in the hepatocytes. Then at the muscle level, there is decrease in uptake of glucose by the muscles. This is due to downregulation of GLUT4 receptors in the skeletal muscle tissues. Then in the white adipose tissue, there is enhanced lipolysis, and this in turn allows a lot of free fatty acids to reach the liver and instigate hepatic gluconeogenesis, which in turn results in high hepatic glucose output. At the pancreas, overall insulin output is decreased, and a reduction in half-life of insulin due to enhanced degradation and an increased release of biological inactive insulin precursors also contributes to the hyperglycemia that is seen along with excess of thyroid hormones. And the last mechanism contributing to the hyperglycemia and conversion of pre-diabetes to frank diabetes, and aggravation of pre-existing hyperglycemia in a known type 2 diabetes is the enhanced glucose absorption at the gut levels. What about hypothyroidism? Hypothyroidism may be falsely increasing the levels of HbA1c test, and there are two references quoted at the bottom. Both of them happen to be ingenious Indian authors. They have, let all of us be aware of this possibility. And while thyroid hormone therapy decreases the HbA1c test results, so when we, give thyroid hormone replacement therapy to hypothyroid patients, HbA1c may come down from the pre-treatment level, which may suggest an improvement in blood sugar control. But when we go to actually repeatedly measure fasting sugars or subject these patients to glucose tolerance tests, the reports remain unchanged on thyroid hormone therapy. So this may lead to errors in diagnosing pre-diabetes and diabetes in patients with hypothyroidism. Now I'll look at some clinical pitfalls in patients who are harboring both diabetes and thyroid disease. So, can I request all the esteemed colleagues to mute themselves? So first I'll look at the effect of anti-diabetic drugs on thyroid function in patients with type 2 diabetes. We start with the good old metformin. It reduces TSH levels, reduces risk of thyroid cancer, reduces thyroid volume and nodule size. What about SUs, which are other commonly prescribed molecules? So they are known to increase the risk of thyroid cancer, increase the risk of hypothyroidism and goiter formation. And pioglitazone has its own inbred issues. It inhibits the activity of thyroid hormone receptors, increases TSH, increases insulin-like growth factor 1, decreases pre-thyroxine levels, and aggravates thyroid-associated orbitopathy. So it's a big no in at least hyperthyroid patients. Now we will review what do anti-thyroid drugs have as an impact on the glycemic control. So both methimazole and carbimazole have been implicated in the development of insulin autoimmune syndrome, which is basically a rare endocrine disorder characterized by recurrent episodes of severe hypoglycemia, markedly elevated serum insulin, in proportion of which the C-peptide is not rising, and positive insulin autoantibodies. So this cluster of findings would clinch the diagnosis. And what about levothyroxine? It reduces both fasting and postprandial glucose levels in a known person with type 2 diabetes, and in turn it also will reduce the HbA1c levels. Now I will present in the 4 clinical cases. The first case is Mrs. SD. She is a 66-year-old woman with type 2 diabetes diagnosed 6 years ago. Her fasting sugar levels hover between 110 to 119 on an average. And despite several suggestions and education given to her, she is still refraining from looking at her 2-hour post-meal sugar levels. Luckily, she has no known macrovascular or microvascular complications till she presented to us with a BMI of 29 and complaints of fatigue and weight gain. She is on a fixed dose combination of glimepiride 2 mg plus metformin 1000 mg twice daily before major meals. Now, this has been going on since quite a lot many years, almost since the diagnosis. And unless a clinician screens her for thyroid disease, her complaints could be attributed to the usual course of type 2 diabetes or could be dubbed as being iatrogenic. Means glimepiride would be one of the culprits. So, female gender, central obesity, that is visceral obesity, presence of diabetic nephropathy, elevated HbA1c levels, and longer duration of diabetes, all of them have been implicated as risk factors of thyroid dysfunction in patients with type 2 diabetes. Coming back to the case, the initial dose of levothyroxine in such individuals as this Mrs. SD, 66-year-old lady, would be highly individualized. And what we would be looking at the cause of the disease, severity of the dysfunction, his or her health and age. So in the elderly or those with underlying CVD, start low and go slow with drug titration. And Mrs. SD is likely to see improvement in her symptoms within 6 to 8 weeks after initiating levothyroxine replacement therapy. Now I come to clinical case 2. She is Miss NM, 27-year-old woman with type 2 diabetes, diagnosed 4 years ago. Since her diagnosis, she has lost 12 kgs through a diet and exercise program. So she has been on the whole lifestyle adherent. She is currently having normal blood sugar levels. Her comorbidities include polycystic ovarian disease and vitiligo. So part of that is shown in, muted photograph on this slide. And family history is significant for thyroid diseases. She was taking metformin until a recent positive pregnancy. So in PCOD, one has the luxury of continuing metformin for first 3 months, and well, the better sense is to straightway put such patients on required dose of insulins. The patient complains of fatigue, nausea, constipation, and feeling cold. Now, her weight loss, which she had registered with immense efforts over a period of 4 years, it plateaued several months ago, and now her weight is slowly increasing. So, physical examination is unremarkable except for a 30-gram thyroid picked up on sonography of the neck. So, normal weight of a thyroid gland in a healthy adult without iodine deficiency is around 10 to 20 grams. Lab results show HbA1c of 6.6, free T4 of 0.5 nanogram per deciliter, a TSH of 13.4 elevated, micro international units per ml, and C turned positive for anti-thyrox TPO antibodies, peroxidase antibodies. And hence, a referral to a dietitian is recommended to evaluate adequate calorie intake for diabetes, pregnancy, and appropriate weight gain. And I am very happy that I have at least 2 of the 3, to the best of my knowledge, who are very reputed dietitians chairing my session. So thank you, madam, for joining me on this platform. I am in fact delivering my talk from US. I am in the US, and it was kind of Dr. Misraji to allow me to present in this manner. And then swift initiation of levothyroxine therapy is indicated because the patient is hypothyroid and pregnant. Initial symptoms should improve within 4 to 6 weeks unless they are secondary to the pregnancy rather than hypothyroidism, which happens rarely. Most of the time, there is remission of symptoms. Our own flagship body, RSSDI, recommends that we must, as a part of preconception counseling, recommend to all our type 1 diabetes ladies before they think of conceiving and becoming pregnant, we must recommend TSH along with TPO antibody tests. And women with positive TPO antibody must be screened at 3 and 6 months of gestation and at 12 months postpartum. Patients with type 2 diabetes, pre-diabetes, GDM, and risk factors such as obesity may also be screened for thyroid dysfunction during the first trimester of pregnancy, regardless of their levels of diet. Even if they are most optimally well controlled in terms of their sugar, they have best time in range readings on a CGM, or they are clinically absolutely euthyroid, still it is our moral duty to subject them to at least thyroid screening tests. Now I come to clinical case 3. LM is a 32-year-old man with type 1 diabetes who uses an insulin pump. So he's an affording guy, and he's educated and street smart, uses the insulin pump correctly. He presents with tachycardia, shortness of breath, fatigue, muscle weakness, double vision, weight loss, hyperglycemia, anxiety, nervousness, heat intolerance, and increased frequency of bowel movements. So these are all symptoms classically confirming the hyperthyroid status of this individual guy. On physical examination, his skin is moist and warm. He has blisters with an orange peel appearance on both lower legs. He has bilateral proptosis, a bold stare, lid leg, scleral injection, double vision with eye motility, and diffusely enlarged thyroid form in textures weighing around 60 grams. He has a baseline tachycardia, heart rate of 106, and luckily no murmurs. His lungs are clear to auscultation, lower extremities display pretibial myxedema in lower legs, and neurological examination reveals hyperreflexia in this individual. Looking at his total T4, it's around 22 microgram per deciliter. TSH is less than 0.01 micro international units per ml. Thyroid stimulating immunoglobulin, which is a diagnostic test which helps in, making a confirmed diagnosis in such individuals. It had an activity level of 300%. Normal values are less than 130% of the basal activity. That is how most of the standard labs express the results of this particular test. Fasting blood glucose was 345 and A1C was quite haywire, 9.2, despite using a pump. So that means, though he is educated, probably he is indiscreet in terms of lifestyle and food habits. And his I-131, that is iodine 131 radio pressure imaging, revealed a 77% uptake in 4 hours. Normally it is around 4 to 12%. And a DEXA scan revealed osteopenia at the spine and hip level. So treatment strategies in such individuals would include beta blocker therapy, an increase in insulin, especially as we might be tempted to offer this guy oral steroids for his ophthalmic issues, as well as discussion of various options available to this gentleman, including radioiodine therapy, ablation therapy, surgery for removing a part of thyroid gland, or antithyroid therapy. And we need to provide him education not only in regards to thyroid issue, but for his diabetes control also. There is an autoimmune link, HLA-LLs, especially HLA class 2 and CTLA4 gene have been implicated between type 1 diabetes and Graves' disease. The prevalence of now I am referring to Graves' disease per se. Disease with type 1 diabetes has been reported to be around 2.7% in men and variably reported from a low of 2 to around 19% in females, in women. So patients should be monitored closely to evaluate their response to thyroid therapy as well as their diabetes control. Now I come to the last case of my presentation. A 32-year-old man with an 8-year history of type 1 diabetes presented with an unintentional 10 kg weight loss but an otherwise normal physical examination. He didn't have the symptoms that was seen in the previous case except for the weight loss. Laboratory studies revealed a suppressed TSH concentration and an elevated FT4, both suggestive of hyperthyroidism. His anti-TPO antibodies were positive, but his thyroid stimulating immunoglobulin test was negative. So basically a thyroid stimulating immunoglobulin test measures the amount of TSI in the blood. TSI is an antibody that tells the thyroid gland to become more active and secrete more hormones. Uptake of radioactive iodine by scanning was just 0.5% instead of the normal 4 to 12% we saw in the previous case at 24 hours. The patient was diagnosed with autoimmune thyroiditis. 6 weeks, please mark this, 6 weeks following his initial presentation, he became clinically and biochemically hypothyroid and was treated with levothyroxine. So what this important case teaches us? This case demonstrates that autoimmune thyroiditis can present initially as hyperthyroidism in a man with type 1 diabetes. And autoimmune thyroiditis, we must remember, may be an isolated phenomenon of autoimmunity or maybe a part of autoimmune polyglandular syndrome. So I have just in a separate box inserted that. So APS type 3 would be autoimmune thyroid disease plus other autoimmune diseases excluding some of them. Among patients with type 1 diabetes, hence, who present with hyperthyroidism, Graves' disease and other forms of hyperthyroidism need to be excluded as autoimmune thyroiditis can progress quickly to hyperthyroidism requiring thyroid hormone replacement therapy, as we saw in this particular case. So I come to the end of my presentation. There are two key takeaway slides. Autoimmune thyroid dysfunction occurs in 17 to 30% of adults with type 1 diabetes. Here I have not specified whether it is Hashimoto's or Graves, but overall clubbed together, autoimmune thyroid dysfunction occurs in around 17 to 30% of adults with type 1 diabetes, global statistics. Thyroid dysfunction is more common in patients with type 2 diabetes than in the general population. Pre-existing diabetes mellitus is exacerbated by hyperthyroidism. We saw in that couple of slides. Insulin treatment should be adjusted in patients with diabetes. This is a very important recommendation after the occurrence of thyroid dysfunction. Either ways, hypo or hyper, we have to, monitor and modify the insulin dosage. Hyperglycemia should be re-evaluated in hyperthyroid subjects after the control of thyroid dysfunction. So in the case number 3, he was type 1 on insulin pump, and if we are able to optimally correct his hyperthyroidism, his requirement of insulin may drop a bit. And liraglutide, we must remember, is the popular GLP-1 receptor agonist, is not recommended in patients with a personal family or a family history of medullary thyroid carcinoma, that is MTC, or MEN type 2, that is multiple endocrine neoplasia. MEN type 2 is just described here in brief for everybody's, for recap for everyone. MEN2 syndrome usually causes parathyroid, thyroid, or adrenal gland tumors, which may be benign or malignant. And lastly, pioglitazone should not be administered to diabetic patients with clinically active Graves' ophthalmopathy, because it is known to worsen that condition. So thank you very much for your patient hearing. I hope I have finished my talk in time. If there are any questions, criticism, comments, everything is welcome.
Thank you so much, sir. It was very enlightening. Actually, we can come to know that if the patient is in pre-diabetic stage and if we have not seen the thyroid parameters, it should be done.
Yeah.
Otherwise,
It should be done.
yeah. Otherwise, it can be a fake report. Any questions
Yes.
from the audience? Sir, we don't have any questions. Thank you so much for joining us.
Thank you so much for allowing me to finish my talk. Thank you.
Thank you.
Thank you, Ms. Asad. Thank you,
you.
everyone.
Thank you. Now, without further ado, I would like to invite Dr. Pallavi Mishra ma'am and Dr. Ashutosh Mishra sir to felicitate Dr. Abdur Nazar, DIG, Medical GC, Chandoli, for the hero for fight against diabetes. Sir. We welcome you, sir, on behalf of Cardiabcon. Thank you, sir.